Did you know that a random PCP may be responsible for your health, even if you've never seen this doctor? This isn't a mistake. It's a feature at the heart of our modern healthcare system called value-based care. Welcome to PCP Lens. My name is Sudeep Bensal, and I'm a primary care physician. In this video, we'll unpack the confusing details of how health plans assign patients to doctors and the toll it takes on primary care. Let's get started. If you watched my last video on value-based care, you may remember the value equation. In this equation, value is calculated by dividing health outcomes by cost. But in order to calculate value, we need a population in which we can measure the health outcomes and the cost of all treatments given to people in this population. And then we need a medical provider who would be held accountable for this population to the insurance company. Enter your humble primary care physician, the scapegoat for all healthcare's financial problems under value-based care. Your PCP's panel of patients are the attributed patients in a value-based contract. And under these contracts, your PCP is responsible for every healthcare cost, and it does not matter if they have any control over these costs. For example, I practice in Connecticut, but if one of my patients travels to California, develops a blood clot in their leg because of the long flight, and gets admitted to the hospital in California, all of those healthcare costs in California are attributed back to me in Connecticut. So why did the health plans use PCPs for patient attribution? Well, it's because PCPs have a panel of patients, and they are considered an entry point into the healthcare system. That is, patients will go to their PCP first if they have any medical issues, and they generally control downstream referrals to specialists. And most importantly, it is easier to hold one person accountable than the entire medical system. Once the powers to be have determined that PCPs will be held accountable for all the healthcare cost and quality, then the next step becomes to figure out who is a PCP. So how do we determine who's a PCP? Traditionally, pediatrics, internal medicine, and family medicine are considered primary care specialties. However, this designation is becoming much more complicated as doctors in these specialties are increasingly performing non-traditional work. And these non-traditional roles include hospitalists, that are doctors that only take care of patients admitted to the hospital, SNFists, that is doctors who are working in a skilled nursing facility, locum tenens doctors, that is doctors who travel and fill temporary positions throughout the country, and doctors working in urgent care or retail clinics such as CVS Minute clinics, and also doctors providing virtual care only. Now, to get around some of these non-traditional roles, health plans use several methods to determine the PCP status. So for example, how is the physician credentialed with the health plan? That is, when a doctor signs up to accept patients from, let's say, Anthem or Aetna, did they tell the insurance company they're a PCP? They also use job taxonomy, the skills classification system that is used when registering with health plans, and also by requiring patients to pick a PCP from the insurance website manually. However, all of these methods fail when doctors work part-time or they work in different roles. The best example of this are gynecologists. Several young women, especially those without significant medical issues, use their gynecologist as their sole provider. This raises two problems. Should we consider gynecologists as PCP for women receiving their entire care from them? Also, since gynecologists care for patients on a consulting basis, generally from a referral from a PCP, should they become PCP for these patients too? The same problem exists when doctors moonlight in urgent care centers, take care of people admitted to skilled nursing facilities, or work part-time for virtual care companies. For mid-level providers such as nurse practitioners and physician assistants, this gets even more complicated. There are very few specialty designations based on board certification for mid-level providers. Most NPs and PAs working in specialty offices have a generalist board certification. This makes it very hard to determine whether a mid-level provider is working as a PCP or a specialist. A couple of ways that the health plans have tried to solve this challenge includes determine the PCP status based on the supervising MD or DO. If NPs don't require a supervising provider, how are they credentialed with the health plan? Now that we have a fairly good idea how a PCP is defined, the next question is, should we assign patients based on the PCP that saw the patient in the past, or put on a magic lens to predict which PCP will see this patient in the future? Retrospective attribution looks at which PCP provided care in the past within a defined time period, that is, a look-back period. Different insurance companies may use different look-back periods, and they generally vary from 1 to 3 years. If a patient has had multiple PCPs in this look-back period, then the attributed PCP may be based on either the PCP that provided the most care, which in turn can be based on the number of visits or the total amount of money paid out to the primary care physician, or the PCP that provided the most recent care. Starting to get confused? Let's make this even more confusing. Prospective attribution. This tries to use the magic of data prediction models to see into the future. That is, which primary care physician will provide care to patients in the future. However, since we cannot predict the future, the insurance plans have to perform what's called an attribution reconciliation to make corrections to the predictions after the measurement year. So if the measurement year is 2022, then sometime in 2023, the insurance company will make corrections and reassign all the patients to the PCP based on pre-specified criteria or the retrospective attribution model. Now, to be fair to insurance companies, they do try to get the attribution reports as accurate as possible, given the data that they have. And these reports may be distributed to PCPs or flagged in the electronic health record by the accountable care organization. However, since people are constantly changing health plans or due to other data quality issues, patients are added or removed every month from these reports. Whichever attribution model is used, either retrospective or prospective, approximately 3 to 6 months after the measurement year, health plans will perform what's called an attribution reconciliation based on some pre-specified criteria. All health outcomes and costs are then calculated based on these final attributed patients. So PCPs are always guessing which patients they will be held accountable for till the final attribution is done by the health plan approximately 3 to 6 months after they can do anything to meet the metrics that they're being held accountable for. Now, one can reasonably argue that PCP should treat all patients equally, and health outcomes should be similar across all patients irrespective of patient attribution. However, if you read my previous articles or watched my previous videos, you may realize that your humble PCP is being held accountable for socioeconomic and environmental health determinants of care under value-based contracts. As part of an ACO, the PC may have limited resources and will want to use these resources on patients attributed to them. The best example to illustrate this point is transportation. If patients don't have access to transportation, their PCP via the ACO will try to prioritize providing transportation to these attributed patients so that they can go and receive healthcare so that they don't get admitted to a hospital. The government, on the other hand, can build transportation infrastructure for everyone. And yes, under value-based care, PCPs or their ACOs in which they participate are put in the position of arranging and providing for transportation, housing, or helping with any socioeconomic determinant that may increase the cost of care. Because remember, if we cost the insurance company a lot of money, we have to pay them back. Insurance companies are not only making profits off your premiums, but are now running the scheme to claw money back from the health system so they can distribute it back to the shareholders. By the way, if you're watching this on YouTube, please like and subscribe. If you're watching on PCPlens.com, and if you've not subscribed, please consider becoming a paid member. Okay, let's get back to our confusing attribution problems. Besides the confusing issues on attribution that we've already discussed, there are other problems. If there was no PCP visit in a given year, then the patient is attributed to a specialist that's provided the most care during the look-back period. For example, if the patient saw a cardiologist only for heart issues, the patient may get attributed to the cardiologist, making the heart doctor responsible for all the quality metrics. If a person is healthy and has no contact with the medical system, the insurance company either forces the patient to choose a PCP from the list when signing up or automatically assigns one. This is how a PCP somewhere becomes responsible for all the quality metrics and health outcomes for a person they've never met. And I have been automatically assigned as a PCP for someone that I have never met and told by the insurance company that I'm not taking care of these people. And then there are attribution issues for people who are very sick. For example, those with end organ damage. These people are predominantly managed by specialists. Yet, under most attribution models, these people are still attributed to their PCP if they saw their PCP even once during the measurement year. To make the attribution confusion even worse, there are 171 unique attribution models that have been proposed or are currently in use in value-based care. And each health plan uses its own model. You can imagine why PCPs are left wondering why some patients are assigned to their panel while others are not. Now that we understand how patients are attributed to PCPs, let's take a look at the toll it takes on primary care. Under a fully capitated value-based care model, providers will be paid monthly for attributed patients. Currently, it takes an average of 3 to 6 months for patients to be attributed to a primary care doctor. Under a fully capitated value-based care model, providers will be paid monthly for attributed patients. Currently, it takes an average of 3 to 6 months for patients to be attributed to a primary care doctor. This means that new practices will not generate any revenue during the first 3 to 6 months in spite of taking care of people, or this payment could still be going to the patient's prior PCP. Also, today it takes approximately 2 years for a new medical practice to become profitable. Under the value-based care model, due to delays in attribution, it'll take several years for new PCP practices to become profitable. It's already hard to start a new primary care practice today. I know this because I started mine from scratch in 2018. And these delays in patient attribution will make it unsustainable to start a new primary care practice. Now, there are ways to get around this issue, such as asking every patient seen in the new practice to go to the insurance website and change their PCP. But we're taking a simple payment model and making it more complicated, both for the PCP and the patient. The next issue is that there's often a mismatch between the patient's real panel and patients attributed to PCPs by health plans. The difference between this mismatch depends on the attribution algorithm used and also the type of patients in the practice. For example, if there's a high patient turnover in the practice, such as higher proportion of people relocating for jobs or school, the attribution is more likely to be wrong. Also, if a provider is working in different roles, for example, if a patient is being seen by a PCP in a skilled nursing facility or an urgent care center, there may be several people misattributed to these doctors. Again, there are ways to compensate for these issues. Example, the billing codes in skilled nursing facility visits are different than office visits. But this makes attribution algorithms more convoluted and opaque. Furthermore, since these algorithms are controlled by health plans, they have the final word on who is attributed to a PCP. This mismatch in attribution panel may penalize or reward another PCP at the expense of the other. Even worse, health plans may attribute high-cost patients who don't have a PCP to an ACO doctor who saw the patient in an acute care setting, such as a skilled nursing facility. This will raise the total cost of care for the ACO and decrease the chance of shared savings in these value-based care contracts. The onus then falls on the PCP and the ACO to investigate and challenge the health plan's incorrect patient attribution, which then increases administrative workload and takes time away from patient care. Then there's the public humiliation by posting quality metrics online for everyone to view. Now, I understand the logic that publicly posting quality data will force organizations to provide better care. For small practices due to patient attribution problems and not having staff to submit quality data to prove that in fact they did provide high quality care can cause large swings in quality metric performance. This can be very disheartening to doctors when publicly posted quality data is completely wrong. This can easily lead to provider burnout or them selling or closing their practice. Thank you for watching this video. You can find a written version with references to the material that I discussed in this video on PCPlens.com. You will also find an audio podcast version of this video on PCPlens.com. If you're watching on YouTube, please like and subscribe. This helps me find a wider audience and help spread the message. If you like this video, please sign up on PCPlens.com so that you don't miss the next episode on how insurance companies make you look sicker to make billions of dollars in profits. Thank you for watching. See you next time.